everybody. Welcome back. We are here for our 15th Facebook Live with myself, I'm Rachel, and Dr. Jemsek. We are covering the puzzle that is LBC. Dr. Jemsek is going to start us off talking about a new study that we have in abstract form, working and collaborating with Dr. Trad. So I'll turn it over to Dr. Jemsek.
Thank you, Rachel. Before we do that, I want to express my thanks to everyone that followed my daughter's story, which had so many thousands of views and reaches. And I think she was very courageous to do that, and obviously had a big impact on the listeners. And I must say, God has a wicked sense of humor. It goes without saying. But she did an artful job, and I'm very, very proud of her. And it did her a lot of good, too. Obviously, she was a bit nervous, but didn't really show that. And once she got going, she was very articulate and fluent. And I really commend her, and I think it did her a lot of good, and I hope it helped a lot of listeners as well. So JSC is now a year and a half into doing live streams. This will be our 15th hour. Everything's on tape on our Facebook page if you want to go back and look at some of the old reviews. But this one is on the puzzles of LBC and just continuing to try to answer some of the mysteries and misconceptions. And so thank you very much for your questions, because they really guide, where we need to go. Now, in the future, I made a decision to be a little more specific about our rationale for the way we treat people and on which basis. And that's something I've been doing for years. I've lectured on. And I believe Kim Fogarty will be with me in a few weeks to help present that. So look forward to that. And today we're going to talk about an exciting new study presented as an abstract at SAGES, S-A-G-E-S, which is surgeons associated with gastrointestinal and endoscopic surgery. And it's an international meeting, and this year it's held in Las Vegas, mostly virtual. I work with Dr. Trad, who's with Reston Medical Group. He's a clinical professor at GW, and a very good colleague. And so we have a collection of over 60 patients, evaluable patients, which is a lot of patients. And our condition is called chronic acalculous, which means no stones, cholecystitis. I believe we posted that, and we posted the abstract. This is a disease that I diagnosed many years ago, and we look at it as an obstacle, a roadblock to starting therapy or continuing therapy, and we have many roadblocks, and we need to post those roadblocks for you because we have two dozen or more, and this is one of them, and it's very important. So if any of them, my patients are out there listening, been examined by any of us, we probe, fairly vigorously. We do a thorough exam. And by the way, if you go to a physician or consultant and they don't touch you, then you haven't had a full exam. And we think it's very important to probe and palpate, and we found a lot of things that way. So we find stuff. And this is how we found this disease, which is essentially a new surgical disorder. It's not in the textbooks. Again, it's called chronic acalculous, meaning no stones, cholecystitis. And Rachel's going to show you the abstract that I had framed. And I know you can't see that, but it's on the Facebook page. Why is this common? It's common because not so much the spirochete invades the gallbladder tissue, it invades everything. That's not what creates the inflammatory mass and chronic inflammation, again, without stones. Our patients typically have nausea, bloating, some reflux, sometimes referred pain, not necessarily pain after a fatty meal, but just have, quote, indigestion and are uncomfortable. Sometimes they have pretty significant pain and double over. But on examination, in that specific quadrant, whether it's the outside the abdomen or on the right side, or whether it's more towards the center of the abdomen, wherever the gallbladder lies, that area is going to be quite tender, and pain will persist, or discomfort will persist, or nausea, or some noxious symptom will persist for several minutes. And that's a good sign that you've got an inflamed gallbladder. And this happens in adolescence, even pre-adolescence. So it's all ages. It's not just you're 40 years old or 50 years old and you have stones. It's a different disease. So we're very proud of that. And in the spring, we're going to publish a paper subsequent to the abstract. We just felt like we needed to get the name out there in an abstract form, and it was accepted by this prestigious international surgical forum. And now we're going to publish, and I should be first author on that. And so there's a reason why we poke on you firmly when you come in for your examinations. And this resulted in the finding of a very significant syndrome and event, which really needs to be attended to before we go on with therapy. Thank you, Rachel.
Mm-hmm. Yeah, that's really exciting for our clinic and for Dr. Trad. So the next question that we have that you guys sent in to us, which keep them coming, how has contracting COVID affected LBC patients?
Well, it's not good. As you know, we feel LBC is triggered by any sort of noxious stimulation or event, inflammatory event, traumatic event. Can be a car accident, can be hormone change after pregnancy, can be another infection, it can be another tick-borne infection, it can be just persistent stressors, multiple stressors. At some point, the immune system dips and the spirochetes take over. So COVID obviously has center stage and deserves center stage for the time being, but there's an interplay with COVID and LBC. There clearly is an interplay. We can talk about long COVID syndrome, but there is an interplay. And so if we have a fragile patient we're trying to nurse through treatment and they get hit with COVID, that's destabilizing because it's another stressor. Or COVID may precipitate elicitation of all sorts of neuropsychiatric, multi-compartmental neurologic symptoms, constitutional symptoms such as fever, chills, sweats, musculoskeletal symptoms, GI symptoms, insomnia, new pain, and so forth and so on, just like our friend LBC does. And so the question becomes, is this COVID doing this for months and months, or has it awakened subclinical opportunistic infections?
And just to follow up to that question linked with COVID, how can the COVID vaccine affect a Lyme patient?
Well, thanks for the easy question.
You're welcome.
Right. We're nervous about our patients getting COVID vaccine, quite honestly. I wish there were more data. I wish that, and the data continue to come out, and yet we have mandates that are a little bit oppressive. So we try to protect our patients. And really, we've had some bad outcomes in patients that anecdotally would come in and say, oh, yes, I had the vaccine. And so, if they do have the vaccine, they say, well, I got the vaccine, Dr. Jemsek. And I said, well, God bless you. I'm glad you survived. But now here come the boosters, and I worry about destabilization of our patients that haven't reconstituted their immune system. I really do. And I think it doesn't take a lot of a leap of faith to understand that, yeah, if you've got a fragile immune system, and you bring in another major antigen with, quite frankly, unknown consequences in a whole range of hosts, you may engender some ongoing neurologic symptoms that can last quite some time, or neuropsych symptoms. And at the very least, you may have 2 weeks where you're just down and out and then slowly recover. Now, the natural infection can do this as well. So it's a question of, okay, what's the benefit risk? And I think that question is still up in the air. And I'd like to hear more from other sides, other information from scientists looking at the real effect of the vaccine and doing immunologic measurements and really giving us some good data. We need that.
All right. Our next question is, can Lyme disease cause anxiety, and how do you treat that? So That's one for me. Lyme disease can definitely cause anxiety. I think, without looking at the biologic side of things, Lyme can cause anxiety because of the effect it has on, your lifestyle. It's exhausting. Your brain all of a sudden doesn't work. You're in pain. You're trying to function at work or with your kids. So that's anxiety provoking in and of itself. The other component is that we know that Lyme can infect parts of your brain that can actually stimulate or cause anxiety. The amygdala is a common area that gets infected that we see, and that's a part of your brain that controls your kind of fight or flight, your aggression, your stress. And so when that area gets infected or inflamed, it can cause kind of irrational anxiety that doesn't make sense to you, that you can't control. There's no trigger to. A lot of times we treat this with, kind of lifestyle changes, stress management, but also with GABA agonists that help calm that part of the brain. We also use some classic SSRIs or anti-anxiety medications that sometimes will work just the same. And then the other component would be treating the illness that is causing the inflammation in the amygdala in the first place. So we definitely see anxiety quite frequently in Lyme patients and try to control and stabilize that so that they can get through treatment appropriately. The next question that we had, I think, is another one for me. So this is frozen shoulder common with Lyme disease? Frozen shoulder, for those of you that don't know, is a disease or a disorder that causes literally your shoulder to freeze up, be in a lot of pain, restricted range of motion, things like that. We do see it in Lyme. We know that the spirochete can invade fibroblasts and cause fibrosis or scarring because of inflammation in the joint. And so that is something that we commonly see. We usually see it starting with an injury, but we also can see a higher prevalence within the EDS, Ehlers-Danlos population, or those that have rheumatic illnesses. They can also be a trigger. So the next question would be for Dr. Jemsek. This is after treatment and maintenance, is it normal to feel constantly fatigued?
Well, no, it's not normal. You have to understand in our treatment, those of you who've gone through either oral or IV treatment, we're looking for landmarks. We're looking for blue sky days, hours, and then weeks, and we expect them at a certain juncture. But if there are any outliers that we don't recognize or can't appreciate or are being kept from us, then that will definitely retard the progress. And so, we're not happy if somebody is profoundly fatigued at the end of a treatment program, which lasts about 12 months. It's roughly 100 days of treatment, if you will, with lots of downtime. So we should have been aware of that prior to the end of treatment. Now, we're monitoring our patients, so we should know about that ahead of time. So we carefully ask and we carefully assess for babesiosis, which is, tough to eradicate. We make sure that's eradicated because it's a inflammatory motor that I think drives the bus for this Lyme Borreliosis complex. We look for interpersonal relationships. Are patients being supported? Because I've been fooled before, and we had a whole session on this earlier this year, last year, with 𝗧𝗜𝗠𝗘𝗦𝗦, and we talked about a whole range of toxic relationships that sometimes I don't know about, and I tend to be a little naive about that thing because I want everything to work out well, but I'm not that naive. And in retrospect, there's been some toxic relationships, a lot of interpersonal strife, family and friends. We look for the usual suspects. We keep a careful log of all the outliers, the laboratory work that is abnormal, that's spun down because people are chronically inflamed. So there are a whole host of key coenzymes, vitamins, mitochondrial support molecules, and other molecules which are very important to the normal functioning, normal cellular functioning and integrity. We look at gut issues. Is that being handled properly, or are they still being inflamed through a leaky gut source? So no, it's not common, but here's what's common and expected, and this is what our patients are a little confused about. this is such a devastating disease, and all the damage it does has to be repaired. You need to understand that after a few months of therapy, especially when you start getting some blue sky days in a controlled situation, that's great. But eventually you want to do more with your life, and you do more. You're out walking, you're maybe doing some stretching and toning, maybe some exercise. And these are all signs of improvement and better stress tolerance and moving the needle so that you're not in as much oxidative stress 24/7 as you were when you came to us. So we look at, as I said, all the outliers, and we look at everything that we understand may retard progress. And that's what we need to post. We need to put our list up because we have like 25 items. So we're going to be doing that in the next couple of weeks as a part of our website to give you an idea of the things that we look for. So when you treat a complex disorder, you have to know what works and why it works, at least try to understand why it works, what sequence things need to be done, and what prevents people from progressing or what stalls them out. And so it could be a histamine issue, it could be a mold issue in the house that they weren't aware of. That's really become an acute event, if you will. I mean, we ask about that sort of thing. Do we test everybody for mold? No, because I think most people have mycotoxins. But if it's an overwhelming event, yeah, that will stall things out. So there are a whole range of issues that we need to look at. But the point I was about to make is that at the end of therapy, just imagine, we've purged infections from the central and peripheral nervous system and many of the tissues in the body. And the patients have done all the hard work. They've gone through this. We've given them downtime. We've given them mechanisms for detoxification of in several ways. And they live a pristine, low-inflammatory lifestyle in order to get to the goal. Some patients so badly damaged, we have to be more patient, and we understand that. When therapy is concluded, at some point, we have enough experience to know that, okay, more therapy is not really necessary. We need to do what we call maintenance, which is a few days of therapy each month. But there's still a lot of healing to be done. In that case, because all the damage is done, now the tissues that have been purged of infection can finally heal. They have a chance to heal. Otherwise, prior to that, there was no chance. There was no way. Those tissues so badly damaged are going to heal. So they have a chance to heal. So the patient, after our therapy, may be more depressed than when they started because the mood centers in the lower brain are still badly damaged, trying to repair, so they need support in detoxification, neurotransmitter help, and that sort of thing. Fatigue may be an issue. Again, we check for all the usual suspects, but many patients have disuse atrophy and decompensated because they haven't moved their body for a very, very long time. So it's a rehab situation. But so is it common? Yes. Is it something we're happy about? No. But we can usually find the answer, and the patient may take longer, may take more months or even a year or so to get to the point that they get their life back. And that's not uncommon. This is such a devastating disease attacking our very core, our very neurologic centers.
I think that was really well put, and I do think that what's interesting about patients that have continued fatigue at the end of therapy, Dr. Jemsek, I think you put it really, really well. We can get patients to a certain point, eradicating infection, but then it's up to kind of the body to recover, right? So that wellness piece, I think, is the final step, which is kind of rejuvenating those tissues, those cells, so that they can function, as optimally as possible. And that's usually where we see that final step and improvement in, fatigue. But yeah, the wellness side is something that is usually the last step. So the next question that someone sent in after the last Facebook Live, I believe, was, would it be possible to have info on the portal of when and how to take antibiotics and supplements? Dr. Jemsek and I both thought that this was a great question, a common question that we get either in office or via phone consultation. We've talked about it and think that we'll probably put together a handout that we can give to patients, which might be a more appropriate route of giving this information out. But kind of in speaking generally, the antibiotics that we use, we typically would like for patients to take them with meals, so with breakfast and dinner. we have patients on doses and more than one antibiotic that allow for an adequate enough dose to be absorbed, even if being taken with a meal, which can sometimes affect absorption. So typically we'll have antibiotics taken with breakfast and dinner, and the other component is it reduces, side effects such as nausea, dizziness, and otherwise, when taken with food. Other common offenders that need to be kind of taken away from meals or other supplements or prescription medication include probiotics and Saccharomyces. So you guys know that we talk about probiotics and Saccharomyces all the time to keep your stomachs nice and safe. Probiotics and Saccharomyces we like for you to take an hour before or 2 hours after breakfast and dinner, which is synonymous with your antibiotics. Again, to help protect the gut as much as possible and not to have any interaction with any of the medications that you might have. Another common offender is CoQ10, coenzyme Q10, which we tend to see an interaction with Mepron. So a lot of times we'll have you just not take your CoQ10 on days when you're dosing your Mepron or atovaquone. Magnesium is another common offender. It tends to bind to things, so taken away from other supplements or medications is important. And then last but not least is the other binders such as activated charcoal. Their main purpose is to bind to things to remove toxins from your body, of course. And so taking those away from prescription medications so that you're not getting reduced efficacy and absorption would be important. But again, I think that we'll put together a handout to give patients kind of an easier idea of how to space out their medications and when to take them and with what. The next question is for Dr. Jemsek, and the question is Lyme an STD?
Short answer is yes. It's a guilt-free STD. It doesn't fit the classic diagnosis of sexually transmitted disease. But despite all the controversy, there's just no question it's sexually transmitted. And I think it's vertically transmitted as well. So I'm not really going out on a limb here, even though this is something that CDC abhors. Common sense will tell you that a spirochete that is as versatile and prodigious as Borrelia burgdorferi, which is probably the top of the food chain of all the bacteria in the whole of bacterial kingdom. It has more chromosomes and plasmids and than virtually any other organism. A lot of its features are unique, quite honestly. It's built to survive. It has multiple life forms. But it doesn't act alone. That's what co-infections are about. So I would put out a thought out there that what if we're all infected with the spirochete? Because once it's in, it's in. Akin to the herpes virus is herpes simplex, the cold sore virus. Grandma gives you a big sloppy kiss when you're 4 months old, and she gives you herpes virus, and you don't get sick, but later on you might have some issues or not. So. Given as part of our flora, which is 500 trillion organisms, and we have no idea which strain, is involved there. And it doesn't mean we're going to get sick, but if you have the right situation with a cohort of other infections, most of which are also endogenous flora. So it's an STD in that sense because it's sexually transmitted. It's definitely vertically transmitted no matter what the CDC says. I mean, we have 200 families, folks, and they either all went in the backyard and got bitten by, the same family of ticks at one time, or else it was transmitted vertically or sexually between the parents and so forth. But, I mean, it's common sense. If you see what we see, we know, and patients get it. They totally get it. And by the way, Mom and Dad, no guilt. Please, no guilt. I know it's hard, very hard to see a sick child, especially one that may be going through what you're going through. We always ask Mom if she would like to be treated first or would she like the child treated first, and because out of respect for the family dynamic, and we do what the mother requests, what the adult requests. But, we have entire families. So it doesn't mean every single member is infected, but many are. One or both adults, if they're, the majority of the children. And, what's interesting is that we take very thorough histories, and so we go back a generation or two. And, you know, my aunt had MS, and my uncle had rheumatoid arthritis at an early age, and, you know, my grandma had Parkinson's at an early age, and my grandfather had dementia at 50 years of old, or 60, and, you know, it just, you know, so it begs the question, with this insidious, predominantly neurodegenerative disorder, are a lot of our chronic degenerative conditions due to infections, due to combination of infections, manifested, mind you, by lifestyle, by the environment, and who knows what's going on in the environment, and by genetics. So it's not a priori that you're going to, you know, have Parkinson's like grandma. It's just not. Your genetics are different. Not, you know, you have some of those genes, but they're not. You don't have the carbon copy. So the main determinants, as I said, environment, lifestyle, which is generally not a problem with sometimes a problem, and genetics, which affect our immune response. And so I've said some controversial things today. I'm saying that everybody has the spirochete. It can coexist peacefully unless it gets, you know, in a cabal with the other co-infections, most of which are, except for Babesia in my view, are in our body already. And I think they're become opportunistic. So it's all about the immune system staying ahead. But in fact, what we visualize, and I sort of have a visual, is that the immune system, you know, should be here, and then the potential infections of lower virulence are here, although Borrelia is not lower virulence. It's, you know, it's a player. And, you know, if you have an inflammatory storm, the immune system can stay ahead, but maybe that gap narrows. And then here comes the stressors or set of stressors, and the paradigm flips. And now the immune system is playing catch up. And that's very similar to what COVID does, by the way. So COVID gets behind the adaptive immune system. So there's two parts to the immune system, innate, adaptive. In the elderly, those wane and diminish, and that's why the elderly are at risk. But the immune system, instead of giving up, it becomes angry and plays catch up and makes all this noise. That's the cytokine storm. The same thing happens with chronic Lyme borreliosis, quite honestly. The immune system is dummied down and is dumb and needs to be reconstituted. And it's just making you miserable because it's making noise, but it's not controlling anything. And ergo, you have these chronic inflammatory conditions, which is one reason why people get gallbladder disease, quite honestly. I didn't really finish explaining that. If I could take just a moment, I think we're doing okay on time. So my theory about chronic inflammatory disease and why some adolescents or pre-adolescents even acquire this illness, which has a different presentation. And by the way, ultrasound is going to be negative 95% of the time. It won't show stones, it won't show thickening of the gallbladder, it won't show fluid. A HIDA scan is a provocative test infusing a dye, and CCK, which is the pancreatic enzyme, makes the gallbladder contract. Once it sees the fat meal, it gets signaled with their fat meal coming down the channel, makes the gallbladder contract. So if the gallbladder is inflamed, it's going to cause some discomfort or nausea or some symptoms. That's really what counts, and that's what we make clear to everyone. So it's not the classic, I ate a pork chop and, some other types of fat and, I got a tummy ache. It doesn't really necessarily work like that. I think what happens is that with the chronic inflammation, the liver can't detoxify everything that it's faced with, all the reactive oxygen species. In other words, the excitatory molecules that are, in fact, oxidized. And so usually, the liver is a source of glutathione, which accounts for 70% of our neutralizing antioxidant capacity. In this case, it's exhausted. So the bile goes through the liver, comes out the bile duct into, and then is sucked up by the gallbladder. And the bile is hot, if you will, for want of a better term. It's oxidized. And so you've got this oxidative material that's concentrated in the gallbladder. And so what does it do to the gallbladder? It excoriates the tissues, is what it does. I think it makes it much more easy for the gallbladder to be infected. But the main pathogenesis is this 24/7 liver overwhelm, no glutathione. That's why glutathione helps some people taken episodically, but it's a very short-acting molecule. And so the gallbladder gets excoriated, and it's inflamed, and it's its own source of inflammation. By removing it, we reduce the infection load substantially. And so, I think that's the gallbladder story. I can't prove it. Dr. Trad and I would like to do another study in which we do a comparison population with standard gallbladder patients with stones and so forth. But we aspirate bile and we look for all the side effects that are in the bile. And one of the reasons I'm pretty sure about this hypothesis is there's 1 or 2 cases in AIDS patients of subacute or chronic acalculous cholecystitis. And of course, AIDS is, without question, a source of chronic inflammation. Prior to therapy, most of those people died. After therapy, people aren't as inflamed. But with Lyme disease, with so many millions undiagnosed, untreated, they're in chronic inflammatory storms. And so we see a ton of gallbladder disease that it's not been recognized. And so we're very happy to report on that and create a new chapter in the surgical textbooks.
Okay, so we did get a question from our watchers, and the question was our experience with LDN and Lyme disease, and also what is LDN? LDN is low-dose naltrexone, and my experience, at least with it, is that patients have been able to utilize it to help reduce the inflammatory load, allow for better sleep, help with pain to some extent. I feel like there's, in my experience, about 50-50 chance of it allowing for those benefits. Some patients, it's a kind of neutral response. Dr. Jemsek, did you have anything to add about LDN?
Well, no, I think it's generally a very benign thing to try. It does cause, I think it's worse, most notable side effect is insomnia, so sometimes you give it during the day. We start with lower doses and build it up, and sometimes it is a godsend to patients, and other times not so much. The idea is that naltrexone is a narcotic antagonist, and so we're giving 1 milligram, whereas if you're in the emergency room, you've had a heroin overdose, you're going to get 50 to 150 milligrams to save your life, to neutralize the endorphin, the heroin that is, paralyzing your nervous system and so forth. So low dose is, in theory, provoking your body to make its own endorphins. So it's given at a low enough dose not to block that, but to provoke your body to make its own endorphins, which leads to a sense of well-being, may help with sleep, may help with energy. And that's the theory. And there's an LDN society out there, and there's plenty of literature written about it. And we're happy to use it. We consider it a very benign trial.
Thank you for that question. The next question is, can an old infection resurface?
Absolutely. Our goal here is to put the disease in deep remission and keep it there. And so after our year of therapy, whether it's IV or oral, mostly oral is what we do, we watch our patient very carefully. By that point, they should be feeling pretty well. Their boundaries are expanding. They're able to do more. They have physical changes, positive changes on their examination, and we watch them carefully. And our visits, spread out to 6 months and then eventually a year. However, if a patient's been morbidly ill, and we see a lot of that because we see the sickest people on the planet, and because Babesia is the number 1, 2, and 3 reason for people to relapse and stall out. By that I mean they just take a step back. They don't go back to baseline. No one who's learned how to do an low inflammatory lifestyle should go back to baseline unless there's some major overriding horrific, personal issues or other traumas. They just shouldn't go back to baseline. And so they're not happy and they're sick again, and our patients are very self-observant and intuitive, and so they'll say, well, I'm starting to get sick again. I can tell it's been going. And sure enough, on exam, most often we'll find an enlarged liver and enlarged spleen, which is the clinical hallmark for Babesia's back. So what we've been doing the last year or so, and I don't know if you've been doing this, Rachel, but we're retreating. We tell the patient when they get into maintenance and they're so happy, and we have a little bell that they ring here and ring, 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 and everybody applauds and down the hallway. It's really nice. It's our happy bell. And you get to maintenance, can I ring the bell? And most people film it, and it's a big deal. Having suffered from this illness anywhere from 18 months to 18 years, or longer, it's a big deal. However, if you've been morbidly affected by that, you're just majorly decompensated, major injuries due to the infections and cumulative effect over the years, we are telling our patients, okay, congratulations for going to maintenance. You've done all the work. Good for you. Can't let off the gas. Just have to keep on that low inflammatory lifestyle. Yes, you can have a little gluten now and then if you can tolerate. Your body will tell you. Yes, you can have a drink, wine now and then. Your body will tell you. Just make sure you're sleeping, your pain's manageable, and we try to reduce your medication load and so forth and so on. But I really think it's a good idea to treat you with 2 or 3 more months of Babesia treatment. And then you hear a groan. Like, does that mean Mepron? That yellow stuff again? Okay, oh, all right. Oh, well, I'll do it. And we've been doing that. And the idea is to try to, because when we treat Babesia early on, we have to get the bad guy out of the way early on, but our immune system's not helping. So we want to get our patients through therapy, experience wellness, learn how to detox, learn how to keep a low inflammatory lifestyle in every measure imaginable possible. Still, it's not enough. So a year and a half down the road, our immune systems are much more engaged, and they'll help us fight Babesia with the same meds that we used before, or similar meds. So we do it for 2 or 3 months, and then we're back to maintenance. And I think that that's going to reduce our relapse rate from 15 or 20% to hopefully 5% or less. And that's the idea behind that. So yes, people who constantly relapse, the most common reasons that outside providers other than JSC don't do is have a synchronized program for biofilm disbursement and kill what comes out of the biofilm in a sequence, in a synchronized way. And they don't know how to treat babesiosis properly. And Babesia, trust me, lives in the biofilm. So those are the 2, I would say, major considerations for treatment success that are invariably lacking when patients come from other practices.
So the next question is, how should a PCP or primary care provider work with a Lyme patient who can no longer afford to see an LLMD? So this is a really good question as well. We get this question a lot. This disease is expensive, to say the least, in regards to treatment. I think first and foremost, it's important to have a primary care. We always urge our patients when they come to see us that we are their Lyme providers. We're not their primary care. So we need patients to have somebody local who they can reach out to, when they have the common cold or they need to be evaluated for possible strep infection. But having a primary care that you already have a relationship is important in the sense that if you can no longer afford Lyme treatment, you already have a relationship with somebody locally who can give you medical support. So I think, reaching out and educating them about Lyme disease in the capacity that they're willing to, accept is important. The other thing is that, patients can do a lot for themselves without leaning on primary care providers locally, particularly if there's animosity towards Lyme disease. Dr. Jemsek has posted this on the website, which is kind of a self-help guide to giving you little tricks of lowering your inflammatory load and putting you in the best physical place to manage the infection without antibiotics or without a Lyme specialist. And that kind of feeds into a question that somebody had asked during the live, which is, what is a low inflammatory lifestyle? And Dr. Jemsek has just, touched on this a little bit, but, keeping a low inflammatory lifestyle includes, getting, good, restful, deep sleep, eating clean. So, not living off of cake, albeit it's delicious, but low sugar, low carb, low dairy, inflammatory foods need to be eliminated from the diet. staying really hydrated, detoxifying yourself externally as well. So if you're able to exercising as tolerated, going in a sauna, really sweating it out. There's lots of different ways to live a low inflammatory lifestyle. And of course, from a psychiatric standpoint, which I know Jules has touched on before, meditating, seeking help with a therapist or a family member that can kind of talk you through a lot of these things as well is really important. The next question that we had was, is there hope if you have multiple strains of Lyme? The short answer is yes, there's hope. There's always hope. We're very optimistic here. But, if you have multiple strains of Lyme, antibiotic therapy in and of itself is going to help eradicate or reduce your infection load, whether that be from Lyme or different strains and different forms of co-infections as well. Dr. Jemsek, did you want to add anything to that with multiple strains?
We don't know what strains. As I said earlier, we're not sophisticated enough to know what strains, although I can assure you it's not the laboratory strain B31. And I've yet to be able to find a reliable source, maybe somebody out there can send me a source of how many pathogenic strains there are. And of course, we're getting new species that are pathogenic, Myomoti and others keep appearing. And but I think the good news is, at least I'm hopeful, that our traditional antimicrobials and anti-infective, by the way, we use antibiotics, but many of you know half of our program is herbal or nutritional. So, yes, we use antibiotics, but we're not an antibiotic farm. And we monitor, and we'll talk about this next session, we modify our treatment based on the targeted organism's lifestyle. So it's not necessary to treat every day. That's what pulsing is. But sometimes it is necessary to treat every day, especially after you've released the organisms from biofilm. You do that for a short period. We always believe in a rest period, because by then patients have learned how to detoxify through sweating, whether it's active or passive, whether it's stretch and tone, or maybe even a walk that you're able to do that you couldn't do at the beginning of therapy, or passive in a sauna or salt bath, drinking hot green tea before you do either procedure, so that you sweat, and taking a modicum of supplements, please no more than 5 or 10, and don't let it, with your diet, just don't put stuff down your gut that's pro-inflammatory. Those are the basics. And then, of course, our poems goes back to controlling pain manageably, having support, making sure we understand what hormonal issues may be outlying, make sure the mood is in the playing field and not askew, so that it's destabilizing, and sleep.
Thank you. And we just got another great question, which I just wanted to touch on really quickly, was asking whether patients go through PTSD and how does one overcome the emotional and mental long-term challenges from this disease. I think this is a really good question, maybe better answered by Jules Capon, but I'm going to take a shot at it. I think that most of our patients probably deal with some semblance of PTSD. I talk to patients about this a lot. I think that there's a PTSD from having a chronic illness, and especially and seen more often when they're on the other side of this illness. So when they are starting to get blue sky days, when they are starting to enter back into society again, getting a job, getting a boyfriend or girlfriend, making those big steps in life. That's usually when I see patients start to have PTSD, because they're looking back and seeing how much of their life they've missed from being really sick, and the toll that takes on them emotionally and physically. So I, typically recommend that all of my patients, whether they're experiencing PTSD or psychiatric symptoms, have a therapist. I think everyone should have a therapist, whether they're feeling depressed or not. But I think it's really helpful for patients as they're kind of coming out of this disease to have somebody who is experienced with working with patients who have had a chronic or long-term illness, be able to help walk them through that. I think that's an important part. And that kind of leads us into our next question a little bit, which is, does having this disease shortens one's lifespan in any way? I'm going to let you start with this, Dr. Jemsek.
Well, so if you don't get the emotional support and you have nothing to live for, I don't want to become too morbid here, but this disease is just simply devastating. It starts taking. Well, first of all, patients compensate sometimes unknowingly when they start to feel unwell, so they may get an extra hour of sleep, and the corresponding example of that on TV is all the pillows that are being sold, and the beds that go up and the beds that go down, and how important sleep is, and the smartwatches that are out there and selling like hotcakes to see how much Delta sleep you get and that sort of thing. So sleep is obviously, the Delta sleep's when our brains rinse and clear out the toxins through its own unique method, and this is well described in a couple of TED Talks. If you don't get that, you carry your toxins into the next day, so that's not good. But parts of, your ability to deal with your environment, deal with your friends, have personal relationships. First of all, if you go back to one of our previous discussions, I talked about the mood condo. I had this mood condo, which is a metaphor, where on the first floor, everybody's irritable. Like, everybody is irritable. That's just how it starts. And then you go to the second floor, and now we have anxiety, not quite bordering on panic, but maybe some PTSD, maybe some early OCD, and some, blue days, bad moods. Next floor, we're getting into outright OCD, manic depression, panic, rage, major depression. And the final floor, depersonalization, derealization, lost all contact with themselves. I'm out of myself. And hallucinations, of course. And so hallucinations are something that is very common. And I just ask the patient, do these freak you out? I mean, because I'm not anxious to add more medication. I can, but if the patient says, no, this guy over here, I think he's reminds me of Uncle Charlie, and I just ignore him, I'm cool with that. Okay, they don't get medicated. But some people get freaked out. Some people have nightmares that need to be addressed, and we have medication for that. But so unfortunately and very sadly, what happens if people don't have help and don't have support is that this disease it's like taking pieces of a scaffold apart and you're on top, working on windows or painting something, and here comes a piece gone, and pretty soon the whole thing collapses. And that's what happens to our patients' lives. And unfortunately, you can become so disassociated and so unrewarded and so uncared for and so unable to communicate that, life's not worth living. And some people commit suicide. But I think the bottom line is, why do people die? Well, they lose the will to live. And they lose the will to live. And it's so sad. And I think it's happening every day, many times a day around the world. And that's why this disease needs to be taken extraordinarily seriously. It is not a trivial disease. It's a real disease, and it's destroying lives, families, careers, and so on. And it needs to be its own discipline. And we need a team of competent specialists to help these people. And not everybody can even afford to go to a doctor visit. And like we said, there are self-help measures, and we need to get that information out to everyone, if possible. And there's some wonderful people who are support people that have the biggest hearts I've ever seen, and they're just lovely and wonderful. I love them. And they'll help other people, but, they get exhausted too. Very demanding illness, whether you're in a relationship with a spouse or it's your siblings or your parents. And, what if you're in a situation where, none of your siblings or your parents believe that you're unwell? How devastating is that? And that happens a lot. So you can feel very alone, very disenfranchised. And after a while, you don't have anything that promotes your self-esteem, and there's not a lot to live for. And I didn't mean to get morbid, but, this is the truth, and I think it needs to be spoken.
Yeah, I was going to say, just in my own experience with looking at this disease shortening lifespans, I think the most blatantly obvious is suicide. I've had a number of patients, not many, thankfully, that have taken their own lives, and I think it is just the toll of the disease. It's just too much, and it's really sad and horrifying for that to occur. But we do see that as one of the primary things that shortens lifespans with this illness. And I think Dr. Jemsek touched on this a little bit, but an important thing for people that are listening or watching that are family members of a Lyme patient is that even our patients that have immense amounts of support are still going through this alone. So a family member can't understand the pain or the anxiety or the cognitive confusion that person is going through, and that's incredibly isolating. And so even if they appear quite normal, the internal battle is pretty profound. So this disease is not fun, to put it mildly. The next question that I think we'll be able to have time for is asking about testing and what the most reliable test is right now. I'll turn that over to you, Dr. Jemsek.
So I think the best of an inadequate lot would be the LA spot, because you're incubating your T cells with a known antigenic source, and you're measuring TNF, which is a little more laborious, a little more expensive, but antibody tests have all kinds of pitfalls, and just it's a slippery slope with antibodies. But the LE spot, and I know there are different generations coming out, I think is the best because it's measuring your own T cells secretion of TNF, tumor necrosis factor, to a known stimulus. But honestly, there are a number of companies out there. The PCR studies are inconsistent. If you have problems with PCR, no matter what the other people say, it's real. I mean, it's hard to. I mean, you're not contaminating the lab. They always say, "Well, it was contaminated by a strain or a series of amino acids in the lab." Well, that's just so dismissive. But the T lymphocyte. So I trust that much more than I do our body's ability to generate antibody, because after all, if that's measured, it's in an artificial system with a standard B31 serotype, and that hasn't changed for 20 or 30 years so far as I know. So no good test, no definitive test. Do we treat people that have negative tests? Yes, we do, because we do such a detailed exam, both historically and physically, that we know what the markers are. And if our patient's checking up boxes, we go forward. And we can always challenge someone with a short course of antibiotics to see if they have a reactivity or if they have a history of reactivity. So we've become, I think, very insightful as to how to put this together and make sense of it to the patient, who's usually quite confused about what's going on with them.
We had another patient write in a question, or person, I don't know if they're a patient actually, about whether we utilize herbals while on IV Rocephin. And, we don't typically use IV Rocephin, but to kind of answer this more broadly, we do use herbals as a modality to support and boost an antibiotic protocol. So anti-malarial herbals are really important. And we do use those with both our oral protocol and our IV protocols, depending on what we're attacking at the time. I think we have time for maybe one or two more questions, so I'll just kind of grab some of the ones that are left. You guys had sent in last time about asking whether mold exposure was something that Jemsek Clinic deals with, and how we approach that. Dr. Jemsek touched on this a little bit. We think that most people are exposed to mold. Mycotoxin tests can be done, but a lot of times you're going to get positives even with minimal exposure. I think we have had some cases of pretty extensive exposure, and we have treated those with binders, but typically we are approaching the underlying disease, which is Lyme, as opposed to mold first. Want to add to that at all, Dr. J?
No, just if there's overwhelming exposure, whether it's acute or chronic, we should have known that from the beginning. But if somebody's reporting now that, oh, we just found mold behind the wallboard and, in the ducts and all that sort of thing, then you go through the extensive process of evaluation and remediation, move to a new home. It can be quite laborious, but it can have a paralyzing effect on the trajectory of treatment and recovery, and we understand that. In looking at the treatments available, we're all about gentle. We don't believe that it should be the primary goal. We think it should be a parallel goal, and we're all about using gentle products to leach, because once if you're in the gut and you're secreting mycotoxins, we want to do that in a gentle, orderly way rather than just grab them out, because that destabilizes the membranes and so forth and so on. It can be quite debilitating. So we're gentle.
And then the other question you guys had posed last time was asking about hyperthermia and what the pros and cons of this are. Kind of feeding off the idea of gentle treatment. Hyperthermia can be more mild, but it can also be quite intense, where patients are put under sedation to be exposed to hyperthermia, actually inducing seizures. In that situation, obviously that would not be gentle treatment. We do know that hyperthermia can kill the Lyme spirochete. We don't think that it addresses the co-infections, and so it's limited in regards to its scope of coverage for treatment. We also have had a limited number of patients who have attempted to go do hyperthermia treatment, but those who have, by and large, I would say, haven't seen huge benefits. So that's our experience with the hyperthermia. I don't know if you have anything to add.
No, I don't know anyone that's had sustained response. By the way, teleologically, fever evolved to help upregulate the immune system. We're talking fever 103, 104. We're not talking 108. So that's the purpose of fever. It's not to kill organisms, it's to upregulate the immune system. So we know that, and that's why with some illnesses we have fever, to help the immune system bolster its effectiveness and strength. But hyperthermia, no, that's a whole different thing. And no, you've got life forms that aren't being touched. You've got intracellular organisms not being touched, and co-infection and so forth. Probably melts biofilm, but I mean, it's just it's a window wash in my view. It doesn't do the whole job.
So I think that concludes our questions for today. We really appreciate you guys sending all of your questions in during the Facebook Live and the questions that we covered from prior Facebook Live events. We look forward to talking to you guys again in a couple of weeks, right?
Right. So, yeah, thanks for tuning in, and keep the questions coming. We love to try to educate, and we learn from you. We always learn from our patients. So God bless, and see you next time.